My name is Rashmi Yadav. I'm a cardiac surgeon at the Brompton Hospital. And today we're talking about treatments of coronary revascularization as well as functional mitral regurgitation. Here with me is Professor Bernard Gersh from the Mayo Clinic. And we were in a very interesting session this morning, you would agree, which was a debate session between the ESC and the ESCTS. And we first addressed the topic of coronary revascularization. The question was, do you think that syntax 2, which is a clinical score rather than just an additive score, is going to change the outcome and the way we manage coronary artery disease?
The honest answer is I don't know, but I like the idea, and that is really that the original syntax score, I think, taught us a great deal about anatomical differences in coronary disease and which anatomical subsets would do better with surgery as opposed to PCI. What I like about syntax 2 is it integrates a lot of clinical variables. And really, when we look at the long-term outcome of coronary disease, many of the major determinants are not the anatomical variables, but the clinical variables. So I like the idea of the syntax score. I think it is a step forward. We're going to have to just wait and see the results in terms of whether it really does improve our ability to predict who should go to surgery and who should go to PCI. I think we do it already. I mean, I think we do it clinically. And we look at age, we look at comorbidities, we look at renal function, and I think we actually make that decision. This will help formalize that or put some structure to it.
Yes, you're absolutely right. And I think looking at the surgical score, the Euro score, it is a very well-validated score and has been tested in up to 22,000 patients for each of the two scores. My slight concern with the syntax 2, of course, is that the numbers are small. They've been tested in about 1,800 to 2,200 patients. And I think if it is to become the score that we want it to be, which will be able to predict 4-year outcomes in patients, depending on whether or not we treat them with PCI or CABG, I think that there needs to be more validation of this. What's your view about that?
Yeah, I do agree. And maybe that we could take that score and apply it to the Society of Thoracic Surgeons database, perhaps retrospectively, and look at it. But yeah, it's going to need to be validated in more people. But I like the idea, I like the concept.
Yes, indeed. And I think the real beauty of it is it can be individualized so that a particular patient score can be predicted, and we can predict not just immediate outcomes but also 4-year outcomes. And I think that will be the real strength and give the patient the choice of what treatment they might prefer, particularly if there's equipoise between the two.
Yeah, more knowledge is better.
Okay, moving on to the second topic we discussed this morning, functional mitral regurgitation. Again, it's a very difficult topic because of its heterogeneous nature. Will you tell us a little bit about?
Well, it was a fun debate, and it is a difficult topic. And I think the one point that we need to make is there is a fundamental difference between primary degenerative mitral regurgitation and functional or ischemic mitral regurgitation. The first is a disease of the valve leaflets and the supporting structures. Functional mitral regurgitation is not a disease of the valve leaflets. It's really a disease of the ventricle, which has an effect on the supporting structures of the mitral valve. So it's much more complex, because I've always had the feeling that surgery directed at the primary cause always has better results than surgery directed at the consequences. So it's, I think the first message for our audience is functional mitral regurgitation is complex. It's not as simple as pure degenerative mitral valve disease.
Indeed, and I think within functional MR then there is ischemic and non-ischemic MR. Would you like to tell us a little bit about your views about ischemic MR and its management?
Yeah, I think that the area of interest is ischemic mitral regurg, because as controversial as it is, I mean, non-ischemic functional mitral regurg, the disease is idiopathic dilated cardiomyopathy, and in the end, the determination of prognosis will be the prognosis of idiopathic dilated cardiomyopathy. And the data that I've seen on repairing the mitral valve in people with non-ischemic mitral regurg are not impressive. And I wouldn't expect that to be, because I really do think the determinant is the severity of LV dysfunction and the progression of the dilated cardiomyopathy. Ischemic is perhaps not nearly as clear-cut, because there is the issue of ischemic heart disease, myocardial infarction, and coronary bypass surgery. The question is, do you address the mitral insufficiency at the same time or don't you? And that's, it's complex. I mean, we need more data.
I totally agree, and I think to summarize, we felt this morning that it was a very heterogeneous disease condition, that the assessment of moderate MR was also complex and needed to be done under exercise and stress conditions, and the treatment needs to be tailored to the patient because there are so many different parameters, particularly LV size, the degree of tenting of the valve leaflets, the annular size. All of these have an impact on the outcome of mitral repair, and there's a choice between repair or replacement in these patients, and it seems to be a complex problem where an individualized approach to patients might well be the way forward until we have more data.
Yeah, I certainly learned this morning. I mean, I think we all agreed one size does not fit all. What I did learn was the assessment has to be made with exercise in many cases, because many of these people have mild to moderate regurg that's brought out by exercise. And then I think the sort of final message from my standpoint is, if the primary symptom is angina and the patient needs bypass surgery and they have moderate mitral regurgitation, they need bypass surgery. If the patient has angina but they also have symptoms of heart failure, symptomatic heart failure and mitral regurgitation that's at least moderate, that's the patient that probably should have an additional procedure. Whether that should be a repair or a replacement is a technical issue, and we need more data. We only have two randomized trials, really.
Thank you very much. That's been an excellent session.
Thank you.
Thank you.